Hi, everyone. I thought I would send you a short recording. I had a couple questions yesterday about sensory fusion from one of your classmates. And since this is always, for some reason, the most difficult, seems to be, for a lot of people, the most difficult thing to understand, I thought it might be worth just talking about it a little bit more and maybe clarifying a few things or talking about it a little bit differently with the hopes that that might help you. So I've got a little bit of a slide deck. Most of it's from the original slide deck, but I changed a few slides around that I think will be helpful. So these would probably take the place of, or listen to that one and then listen to this in addition. So this all has to do with sensory and motor fusion. And so let's see. So sensory fusion is when the visual system combines two images, right eye image, left eye image, combine them into one. Okay, so it has to be something from the right eye and something from the left eye, and they have to be similar enough to be combined, okay? And you are familiar mainly with sensory fusion, normal sensory fusion, but patients with anomalous correspondence also have fusion, okay? And so when they fuse, we would say it's anomalous fusion. Anomalous meaning like anomalous correspondence, anomalous fusion. And so they can, especially your patients with HAC, I always think of them as pretty good, having pretty good anomalous fusion. And so that's the sensory part. And then the motor part is just the vergence, convergence, divergence ranges, positive fusional, negative fusional vergences, and that's the movement of the two eyes, and that's to maintain sensory fusion. And so you know what normal motor fusion is because you learned about that in your BV course. But the thing is that patients with anomalous correspondence can also motor fuse things. And so when they do that, we call it anomalous motor fusion. So this is where I want to deviate a little bit. Now I want to just talk about patients with normal correspondence. So if a patient has normal correspondence, when we look at sensory fusion, if they fuse the image from both eyes, from images from both eyes, that's normal fusion. If they don't have normal fusion, they're doing one or two things. They're either suppressing or they're diplopic. So if you have a patient who has a manifest strabismus with normal correspondence, so this is a really important point. A patient with manifest strabismus with normal correspondence, there's three things that can happen. They can see double, they can suppress, or they can have normal fusion. Now, mind you, I said they had normal correspondence, so AC is off the table right now. So when you have somebody who's NC, they're either fusing, they're suppressing, or they're diplopic. And sometimes you can go from one to the other. So you can be diplopic some of the time, but fusing the rest of the time, or you can suppress some of the time and fuse some of the time. So it's not an all or none. It can change with time. It can change with circumstances. It can change with target size. It can change time of the day, that type of thing. And then the motor fusion, fusional vergence, we typically describe that as either you have enough or you don't. And you either have adequate vergence ranges or you don't have adequate vergence ranges. So we tend to talk about that as adequate or inadequate. So think of adequate as enough or sufficient versus inadequate, not enough or not sufficient. So inadequate, not enough, not sufficient, not so hot, not so good, not enough to do the job. Adequate, enough to do the job, sufficient. So that's what we're talking about. So that's the motor part. So I changed this around a little bit from the first one. So this now says patients with normal correspondence. So I'm only talking about, we're still on the normal correspondence thing. So if you've got sensory fusion, I mean, I think it's very helpful to think of it as a kind of building blocks or a pyramid like this, or you can think of it as a construction thing, a house, in that, in order to have third degree fusion, you have to have second degree fusion. And in order to have second degree fusion, you have to have first degree fusion. So first degree fusion is being able to take the image in the right eye and the left eye, if they're separate, to be able to get superimposition. So think of the major amblyoscope. You've got two different objects. Can you see them in the same place in space? And one inside the other. So it's a primary, or first, I should say first degree fusion. So if you've got first degree fusion and you have normal correspondence, then that means you can superimpose two targets that are placed under focus, okay? So that would be the normal part of that. And then if you're not doing so hot on that, you'd be suppressing. So there are some patients that have suppression so deep that they don't even see both targets. And they could be big. So you could have the soldier in the house, and they only see the house. They don't see the soldier. They only see the soldier. They don't see the house, even though they're peripheral targets. So even though you turn the illumination unequal, even though you flash them. So there are patients who could have very deep suppression who would not get superimposition of first degree targets. Okay, so good, normal would be superimposition. That'd be normal first degree fusion. And then not normal first degree fusion would be suppression. Okay. So I'm thinking of this, when we test this, it typically is in an instrument. Okay, so it's typically in an instrument like a major amblyoscope. So that's why either you have fusion or you suppress. As long as it's normal, those are the two options. Okay, in instruments, something like the major amblyoscope, where you're presenting one target to each eye. Now, second degree fusion, if you can't get first degree fusion, you're not going to have secondary fusion. But secondary fusion is, you can call it whatever you want. Think of it as secondary fusion, think of it as flat fusion, but flat fusion is when you have two targets with similar contours. So there's no disparity to give rise to stereo, but it's similar contours, so you can put them together. And like one of my favorite targets in major amblyoscope, for example, is a cat. So it's got, the body, and then one cat has ears, and then the other cat has a tail. So if you put it together, it's one cat, it's got both ears and a tail. So it has a suppression control on each. And this is different than first degree, because first degree is dissimilar targets. It's just putting one inside the other. It's superimposition. Now, it's not just superimposition. You've got stuff that goes together. You can get it together. So what can happen there, and think Wirth-4 dot. You're very familiar with the Wirth-4 dot. So with Wirth-4 dot, you get what? You either get flat fusion, you have diplopia, or suppression. So it's good or normal if it's flat fusion, and it's not normal, or it's not good, or it's not desirable to have diplopia or suppression. But those are your three choices. In free space, second degree fusion, it's diplopia, suppression, or normal fusion. Now somebody asked me, it just occurred to me when I said that, like, well, how do you find diplopia in the major amblyoscope? And the answer is you don't. So if you're checking second degree fusion in the major amblyoscope, it's either going to be suppression or fusion. There's no diplopia response. It's just not set up that way to do it. So it's either suppression or fusion. In free space, you can have the three of them, okay? And then as we go up the pyramid, if a patient has secondary fusion, they may or may not have stereo, and they're lucky if they have stereo, and you guys all know what stereo is. So now we're talking about there's some disparity in the targets that gives rise to this perception of depth, okay? And in terms of normal or abnormal, it's like good if you have it, and worse if you don't. So there's two choices. You either see it or you don't. And of course, within stereo, there's global or random dot stereo, or local versus lateral disparity. So, so the lateral disparity and local, they mean the same thing. And then global and random dot mean the same thing, but they're two different aspects of stereopsis, okay? And so and they're each separate, because you might not see random dot, but you might get lateral disparity, okay? Typically, if you have lateral disparity and you've got pretty good lateral disparity, like if you're down like 20, 30 seconds, you probably have random dot as well. Okay, so that's for sensory fusion for patients who have normal correspondence. Superimposition, flat fusion, stereo. And that's your, what I've got on there is your normal responses and your not so normal responses. For anomalous correspondence patients, and we typically don't spend a lot of, I don't spend a lot of time testing them typically, okay, for this. But certainly, you know, when we look, I guess I should take that back a little bit because I do the major amblyoscope a lot. When I do the major amblyoscope, I'm trying to determine if they have first degree fusion at angle D or angle S. And if they don't have first degree fusion at angle D and they have it at angle S, it's highly suspicious they have anomalous correspondence. And so when D and S are different, highly suspicious. And the way I'm going to know the difference, if that is in fact a bona fide difference because of anomalous correspondence, I do a Dowse test. And if I see that they're giving me a fusion response when they're actually strabismic, because the eye is moving to pick up fixation, then that tells me that they have anomalous correspondence. So our first degree fusion, we typically do in the major amblyoscope. I'm trying to think, yes, probably mostly in the major amblyoscope. I'm sure we can think of some other examples, but for you guys, just think major amblyoscope. When we're looking to see at the subjective angle, you know, do they have superimposition? Because it's superimposition we're looking at. Now, second degree fusion, flat fusion, we can do that in the major amblyoscope by putting primary or secondary targets in there, right? Or we can do it in free space with a Worth 4 dot or a red lens. And so if they get flat fusion at their subjective angle, then by definition, they've got, you know, it's anomalous fusion, they've got anomalous correspondence. So patients who have anomalous correspondence will often get second degree flat fusion at their subjective angle. But we would say this is anomalous second degree fusion or anomalous flat fusion because they're doing it at their subjective angle, okay? So if I had a patient, what I could do, it's always easy to think about the major amblyoscope. If I had at angle S and they had superimposition, I could throw in secondary targets and see if they could get flat fusion, and I could go throw in third degree targets and see if they would get stereo there. And they typically don't get random dot stereo, but they might get some lateral disparity. It's possible. Not usually very good, but it's possible, okay? Especially like big peripheral targets. The bigger they are and the grosser the stereo, the more likely they might be able to do that. And so testing stereo at angle S would be something you could do after flat fusion. So probably the best examples was what I gave here, like in the major amblyoscope. I think that's a nice way to organize it in your head, because you can think of, you're putting the targets at their angle S, at their angle S. You know, here's first degree, here's second degree, here's third degrees. But if you were in free space, you could, you know, use a Worth 4 dot, and if they've got flat fusion, like the best example is HAC, where you see 4 balls, and then when you do a cover on cover, you see the eye move out to pick up fixation. So that would be anomalous sensory fusion. And that's the best example, I think, is a HAC 4-ball response. And it's also possible if you gave stereo plates, especially stereo that was lateral disparity and like really big targets, peripheral size, that they might get some stereo as well. And if they are getting stereo, we would say it's at their subjective angle. They're using their subjective angle. That happens, and it's usually, it's never usually finer than 70 seconds, and it's usually worse than that, but on a lateral disparity test, they don't get fine stereo. It's maybe gross stereo, if anything at all. Okay. So, and then, so that's it for that. So the terminology, I just wanted you to be think about the terminology, that we're thinking about that differently. Okay, so we've got NC patients and the AC patients, and we're separating them out. Now, when you have somebody who has suppression, so now we're back to normal correspondence. And so if they're suppressing, it's most likely, if that's the major mechanism, it's a patient with normal correspondence. And we can describe that. And we can describe which eye it's in, how frequent is it, what's the size of it, and the intensity. We tend to just say shallow and deep. Like somebody asked me about moderate. I'm like, yeah, I guess there could be a moderate. But it's so qualitative that there's not like good categorization. So I couldn't tell you, like, if you went around and asked a bunch of people in our department, like, tell me exactly what shallow versus deep is versus moderate. I mean, we'd all probably say something a little bit different. I mean, we definitely know what shallow is, and we definitely know what deep is. You know, deep is when someone's suppressing all the time, and, you know, on all your different techniques, regardless of how dissociative they are. Where shallow is, well, it's just your least dissociative. But, you know, I mean, there's a lot of mush in the middle. So don't worry about the mush in the middle, okay? For your purposes, I think, you know, what's important is that you need to know why you sometimes do a Wirth dot with the lights on and the lights off. Because if with the lights on, they suppress, but then you turn the lights off and they don't suppress, that's a more shallow type of suppression. Versus lights on and lights off, you still suppress. That'd be the best example for you guys of shallow versus deep, is what you do on somewhat of a routine basis with Wirth 4 dot, okay? And it's the same thing for the Wirth 4 dot, why you do it far away and why you do it up close. You're just changing the size of the stimulus. So if you're holding it up here, it's a peripheral target, you're testing peripheral suppression, and you walk out across the room, now it's a smaller target on the retina in terms of the angle it subtends, and now you're testing central suppression. So across the room, you're testing central, up here, you're testing peripheral, and if you have the lights on, you know, you compare lights on and lights off, they suppress on both, it's deep. Okay, so we already talked about that. Yep, talked about that. And here, I just really talked about this as well. And so it's natural or unnatural. And I think you should be able to, without like really knowing it beforehand, like if I described it to you, I bet you could put them in order. So I think if you're memorizing this, you're nuts, because I just think it makes sense. You know, most natural is always walking around with nothing in front of your eyes. You just got your two eyeballs, or your two eyeballs with glasses. That's as natural as it can get, okay? And it's when you start putting stuff in front of the eyes, filters, that's when it gets more dissociative. So between the filters, like you can look in something and that's not quite as natural, but you're not putting like red and green and colored stuff on the back of the eye. So in instrument would be the next more dissociative, because you're not doing filters. And then you know the difference between a Polaroid filter and a red filter. There's a big difference. So Polaroid is just, you know, it's kind of dimming things out. And then a red filter, now you've got red and white, but a red-green filter is red and green. So to me, this is kind of a common sense type thing, that once I know this and look at it, I was like, oh yeah, that makes sense. I think of it that way. And, you know, it's the same thing for correspondence testing. You know, someone said, well, why is our after images the most dissociative? And I guess my response to that would be that it's probably, I mean, how normal is it for you to have bright flashes of light where you've got, you know, a big line going vertically on one eye and a big line on the fovea going horizontally the other eye? And so now you're out there and you've got these big after images. To me, you know, that's like even the weirdest thing, because now you've actually got something plastered on your retina, another image. So that's why that would be even more dissociative if we were talking about anomalous correspondence, which we're not, but I thought I'd throw that in. Okay. Come on, do it. Okay, I wanted to make a clarification here. this whole classical view and suppression, this picture here, somebody asked me this picture is actually supposed to be a picture of the back of the eye. So that's why it says fovea and 0 point Z. It'd be like, well, if this is retina, and I know you don't see retinal vessels here, but between the fovea and the 0 measure point, this is supposed to be retina. And so this would be the D-shaped suppression zone. So that is hemiretinal, and it would be nasal retina if this was a esotrope. That said, if you're going to plot that scotoma, which technically the scotoma should be in space, right? So what would be suppressed in space would actually be temporal retina, right? If you're suppressing, I'm sorry, let me say that again. Suppressing nasal retina, which is then temporal visual field. Visual field is what I'm going to say. But that's not a visual field. Somebody thought that was a visual field, and it's not supposed to be that way. But they would have a D-shaped scotoma, and it would just be temporal field because you've got nasal retina. So I wanted to clear up that. And here's pictures. So these pictures, again, this is not a visual field out here. This was just to say, hey, what's happening back here? What does that look like? And we're just saying, hey, it's a temporal D-shaped, and here's a nasal D-shaped. But the temporal and the nasal is the, retina, or what the retina is, corresponds to cortically, obviously. But then they, it'd be opposite in terms of visual field that was suppressed. Okay. And then the only other thing, I might as well just say this too as I'm wrapping it up, is that often we look at what's your sensory motor fusion now, like walking around. I want to know what you're doing. I want to know how you're operating. How are you operating now? And then, okay, now that I know how you're operating, I'd also like to know what the potential is, because the potential is important, because that's the whole prognostic thing. If you want treatment, I certainly have to know what the potential is, okay? And we've got two different ways to do it. It's out of instrument, which would be free space. I always say free space, but your textbook says out of instrument, or in instrument. So out of instrument, in instrument. There's two ways to do it. And the way you differentiate which way you're going to do it is that for intermittent tropias and phorias, you typically just do out of instrument. And for constant tropias, you do out of instrument to say, hey, buddy, how you walking around now? I want to know how you're operating, how your visual system's operating, versus, hey, I'd like to know what the potential is. And in order to get the potential, I need to put targets at your angle of strabismus, at angle D, okay? And in order to put them easily at angle D, then in instrument is the best way to do it, okay? So if we take a look at all our patients out there, we've got constant tropias, intermittent tropia is a high frequency, intermittent tropia is low frequency, and then our lucky phoria patients. So phoria is always out of instrument. I mean, why would I throw someone doing an instrument evaluation on a phoria? And the same thing for an intermittent strabismus. That's just a phoria gone bad a little bit. So that's out of instrument. And it depends. Like if this is really high frequency, then maybe if they've got sufficient motor to keep their eyes aligned for me to do out of instrument, I'm going to do it. And if I can get all the data out of instrument, shazam, that's all I need. But if they're having a hard time keeping fusion and maintaining fusion, then I might actually do out of instrument and in instrument on this patient. And the reason would be is that, well, maybe right now, if they're really high frequency, they're operating a little bit more like a constant tropia, okay? So the constant tropia, we typically do both. We do out of instrument to see, hey, what's going on in free space? How are you walking around? How are you operating? And then let me put you in instrument and put targets at the angle of deviation and, get some potential, some indication of what your potential is. Now, the only caveat there, I'm thinking while I'm talking, is there is one way to look at potential out of instrument as well. I think we should probably throw that in the same category. And that is, if I do a Worth 4 dot on somebody, and they, you know, it's a patient with constant tropia. So I do a worth for that, and they give me some response. Well, now I know how they usually do it walking around, but how about if they didn't, you know, say it's a 25 ET and it's constant. Well, I know they can't diverge because they're constant ET at 25 prism doctors. But I could say, well, what happens if I get rid of the motor aspect of the deviation? I can put them in the major amblyoscope and put them at 25 base out and get rid of it. But I don't always have a major amblyoscope at hand. So there's something I can do very easily when I don't have one sitting around, and that is I can take neutralizing prism. And if I put 25 base out, which is neutralizing prism, now basically whatever they're looking at is going to get bent through that prism, and it's going to be on both foveas of each eye, correct? Because 25 ET, and if I put 25 base out, I now have the images on the foveas of both eyes. So I'd say, okay, I know you can't do 25 of divergence, but let's see what your sensory fusion is if you don't have to do that. And surprisingly, there's a fair number of patients out there that if long as they don't have to do this, they're pretty good on sensory. So they might show suppression on a worth dot, or they might show diplopia on a worth dot, and then so they can do either. So that's important. They might suppress. That's not very good fusion, is it? Or they might be diplopic. That's not very good fusion. It's not normal. And so if I put neutralizing prism there, and now they're like, oh, now I see it. Oh, I had 5 balls. Oh, well, now it's 4 balls. And I follow through with a cover on cover and make sure they're not strabismic. Well, then that means that their potential, they've got normal sensory fusion with neutralizing prism. Their prognosis just like went, whew, really good prognosis. And the same thing with stereo. No stereo, put neutralizing prism, they get stereo. I mean, shazam. I mean, that is like a really good prognosis. Because they're just saying, hey, I just can't do this. If you can get rid of this for me, I'm good, I'm normal, I'm in. I get stereo like the rest of you guys. If many patients stereo just like the rest of you guys, if you can eliminate that motor aspect. So that's kind of just a little bit of review of in instrument and out of instrument. So hopefully that is helpful. And this is just another slide that went through that. I guess I probably got ahead of myself a little bit, because here's the neutralizing with prism. So what I just talked through, look at this slide, and when I was saying if you neutralize with prism, ooh, and they don't have a strabismus, then let's see, neutralize with prism, UCT, bifixating, yes, and then that means good. So you might write good in here. Bifixating, yes, very good. Now let's check motor fusion with stereopsis, okay. Neutralize with prism, no. Well, it just suggests they've got poor sensory fusion in free space, that's all. So they've got poor, not normal, but poor, okay? So hopefully this will help you guys a little bit. I don't want you to get like confused on the semantics. So when we talk about the patient with AC having some fusion, it's anomalous fusion. They can have anomalous sensory, they can have anomalous motor. But remember, anomalous correspondence goes with anomalous sensory and motor fusion. Versus when we talk about normal correspondence, they've either got normal or they don't. And if they don't, on secondary fusion, it's diplopia or suppression. Neither of those are normal. I mean, they're not normal, right? You know they're not normal. So that's like not so hot, poor, call it poor. Or the book calls it unstable. And so for those of you reading the book that calls it unstable, we haven't been using that term because I tend to think of unstable as kind of moving around. And we found that when we used it, some students were confused with that. So we stopped using the word unstable. But I don't know if I have a better word. So not so hot, bad, poor. Poor is probably a good one. Poor, inadequate. That could be, that you could use that as well. And then motor fusion is either you got it or you don't, adequate or inadequate. So just keep those apart. And I think that that will be helpful for you. Okay? Well, thanks a lot. If you have any questions, let us know. And with that, I'm signing off if I can figure out how to sign off here.